Morning, everybody.
Good morning. Good morning, Doctor.
Okay, I think we got the full complement. So it's okay. Alrighty. So this is a text message that I received in the recent past. Hello, Dr. Pass. This EKG is for a 5-year-old who underwent tonsillectomy and adenoidectomy. Maybe had SVT in or around intubation and extubation. Broke each time with 2 milligrams of adenosine. Weighs 20 kilos, so gave 0.1 per kilo. And again, is back up to 160 to 170 beats per hour. I assume that's what it's meant by that. Looks like there are retrograde P waves with a short RP interval. So let me ask Uzoma, if you're on call as the attending and someone sends you this, it says that the heart rate is 160 to 170 in tachycardia, and that there is a short RP interval, what are you thinking about as the possible mechanism for this?
So I'm thinking AVNRT.
Mm-hmm. Right. That's the most likely thing, right? That would have a short RP interval. Sounds to me like you're outside, but that's good. Doing EP even in the wilds of New York. That would be what I would be thinking about. What about the heart rate of 160 to 170? Does that go with or against AVNRT?
So it's lower than I would expect, but generally AVNRT rates are lower than ORT. So,
yeah,
but it's lower than I would have.
Yeah, on average, they are lower. Not always, but it's a sort of a good rule of thumb that can sometimes broken. Okay, so here is the electrocardiogram of that patient that was texted to me. I'm showing it to you exactly how I got to see it with this strange shadow here. Presumably that's the hand of the person taking the picture. And why don't we see if, let's say, Sergey, do you agree that this, what do you think about this EKG? What do you think this shows?
Good morning.
Morning.
So I'm looking through it quickly. So I see in lead 2, for example, that there is a retrograde P wave after the QRS. But then in other leads, in V1, for example, I see that the P wave is actually before the QRS.
Let me blow this up. What do you think about, let me blow this up a little bit. This is lead 2, which you referenced, and this is V2.
Yeah, well, it looks like that the RP interval is more than 70 milliseconds here.
Right.
Which is against AVNRT.
So would you characterize this as a short RP interval?
No.
No. So I think we would agree that when we look at all of them in concert, the RP interval is actually quite long, right?
Yeah.
So
my problem is that when I looked at the lead 2, I actually thought that the P wave was that first deflection, which I guess
you're referring to this, right?
Yeah.
Yeah.
But then in other leads, I was concerned that this is not the case. So,
you know, when I was making this morning's conference, I forgot for some reason to show you the termination tracing, which was sent to me. And interestingly, when this lead was one of the leads projected during termination, and this extra hump remained on the QRS when in sinus rhythm, by the way. So there would be no way to know that before, but you'll have to just take my word that that's the case. So So this is a long RP in tachycardia. So let me just be clear, you know, when in general parlance, when people are speaking about short or long, there's two issues. One is we talk about the 70 milliseconds. If the R to P interval is greater than 70 milliseconds, we typically think that this is indicative of an accessory pathway mediated tachycardia because it takes at least 70 milliseconds to go down the AV node and then retrograde, come back up the accessory pathway and depolarize the atrium. And we say that if the R to P interval is less than 70 milliseconds, as was stated a moment ago, then we would think more likely it's AVNRT. But when we say a long RP tachycardia, or I should say, when people refer to a long RP tachycardia, they're referring to much more than 70 milliseconds. What is typically meant by that terminology is an RP interval, like let's say over 200 or 250 milliseconds, a very, very long RP interval. So I think that in this particular case, the term would be correct to call this a long RP tachycardia. So what do you think is the differential of this then, Sergey? So now you feel more confident because you have this tracing, you have the 12 lead, you see that the initial impression was probably incorrect. This is actually a long RP tachycardia. What do you think, what are you thinking about now when you see a patient who has a heart rate of 160, 170, and who has a RP interval that looks like it's, I don't know, about 200 milliseconds. So what are you thinking now?
ORT.
Okay, could be ORT, but what about this does not go with ORT or standard ORT? Why would, I agree, if the RP interval is greater than 70, we would certainly be more inclined to think of ORT, but are there any characteristics of this particular tachycardia that are not consistent with the diagnosis of standard ORT? Remember, this is a 5-year-old in SVT.
Well, the rate is lower than we would expect, no? In ORT.
Absolutely. Right? What would the rate normally be in ORT in a 5-year-old?
More than 200.
Right. So this is a strangely slowish tachycardia, right? This is much slower than standard orthodromic reaction tachycardia. Doesn't mean it couldn't be, but a little unusual. So any other thoughts on what else this could be?
Ooh. No thoughts,
Okay.
unfortunately.
All right. The mind is empty. Just thinking about the next case. So another possibility, right, is PJRT, right? Remember in PJRT, which is kind of like ORT, you have an accessory pathway that conducts retrograde very slowly. So the RP interval is long in PJRT. As a result of that, patient tends to have a very slow tachycardia because one of the limbs of the circuit is very long or slow in conduction. And so this could be an example of PJRT. What do we worry about with PJRT, Sergey? Let's say I tell you I have a patient with PJRT. What is the biggest concern in patients who have this condition? What can happen to their heart? Hello?
Yeah, I'm still here. I'm trying to remember.
So
I'll have
PJRT
to read about it more.
is associated with cardiomyopathy, tachycardia-induced cardiomyopathy, because patients who have PJRT will oftentimes have a continuous slow SVT. Patient is not aware of it, and it results in long-term ventricular dysfunction and dilation, related to sitting in tachycardia a long time, and they're in tachycardia for a long time because they have such a slowly conducted retrograde pathway that basically virtually every QRS potentially, remember that when you have an accessory pathway, every time you depolarize the ventricle, the pathway is also depolarized in the opposite direction. However, the reason you don't go into SVT is because the atrium is still refractory from the prior sinus beat. However, if you have a pathway that conducts very slowly retrograde, then you can go down the AV node, depolarize the ventricle, come back up the pathway, and the pathway conducts so slowly that by the time the impulse reaches the atrium, it is no longer refractory and tachycardia is potentially induced. And so these patients tend to have a very large amount of tachycardia and have sometimes incessant tachycardia. And this patient, after coming back from the recovery room, to the recovery room from the operating room, had multiple episodes of SVT requiring therapy. And so that thought crossed my mind. Other diagnoses in this could be a form of ectopic atrial tachycardia. Anytime you have a long RP tachycardia, it's always a possibility it's EAT. The fact that it responded to adenosine multiple times is suggestive of it not being EAT, but some EATs do respond to adenosine, so it's not 100%. Okay, so the patient, let's just say the patient keeps going in and out of tachycardia. So you're being asked in the recovery room to treat this, and the patient is still in tachycardia. So what would you do, Sergey? What could you do to try and? Patient, by the way, just had the tonsillectomy and adenoidectomy, so cannot swallow right now, so can't give any oral agents. So how would you manage this?
IV, we can probably give sotalol, maybe.
Okay, yeah, there is IV sotalol, an agent that we have never once used at Mount Sinai, but yes, you can invoke a therapy that you've never seen done. That's possible. IV sotalol would probably terminate this. Any other agents IV that you might have a little more personal familiarity with that you could use?
Esmolol.
Could use esmolol, right? It's not an agent we use very frequently, but esmolol's a very short-acting beta blocker, given IV, that you could titrate up very quickly. Within about 3 or 4 minutes, you hit maximal. You can basically see the effect. That's a reasonable approach. Any other agents you could
IV procainamide.
Right, you could use procainamide. That would probably work very well in this also. Any other agents you could use?
Amiodarone.
You could use amiodarone too. Be a big gun to use, but yes, you could use amiodarone. In this particular case, as you probably know, we used esmolol, and we were able to see termination of the tachycardia within about 10 minutes of starting it, and transitioned the patient to an oral beta blocker, and the patient remained in sinus rhythm. Interestingly, the plan had been to watch this patient overnight and into a fair bit of the next day to be certain that the patient wasn't having unrecognized tachycardia, but this message did not get transmitted to the ICU team, and the patient was transferred fairly early in the day the next day, which was disappointing. But on the other hand, patient had 2 doses of oral beta blockade and was not known to be in any tachycardia on telemetry. So anyway, I'll be seeing this patient as an outpatient. Okay. All right. So the differential diagnosis, Pjrt, we didn't talk about atypical AVNRT. You can have an RP interval that's very long in some patients who have what they sometimes refer to as slow tachycardia, ectopic atrial tachycardia, and then atrial flutter. That would probably be all the differential of this particular arrhythmia that we saw. The fact that flutter would not terminate with adenosine, EAT usually would not terminate with adenosine. These two are the more likely diagnoses. Okay, This is a tracing on a patient that I saw. And why don't we ask Dr. Barris what he thinks about this tracing? What is the rhythm here? How would you evaluate? This patient came in because someone heard an irregular heartbeat.
Okay, so I'm looking at my rhythm strips on the bottom. And let's see here. So I see a P wave before every, oh, actually. So I see, I'm looking in V1 and I'm just looking towards the end of the strip, and the PR interval all the way at the end of the strip is very, very short. And I'm almost wondering if the beat all the way at the end of the strip, the P wave is conducting almost to the next QRS. But it is, I mean, it is extremely short PR interval, especially on that second to last beat.
Do you think I'll point, are you referring to this beat here or this beat?
That one right there.
This one here. So you're saying this PR seems so short to you that you don't actually think it's possible that it can conduct at that rate. You're wondering if this P wave is conducting to that beat. Is that what you're saying?
Right, that's what I'm just wondering. But on the other
So
hand,
what is
I
this?
see, right, that's the other consideration is I'm seeing another deflection in between over there.
So
And
what
there
is
is,
yeah, go ahead. I'm sorry to interrupt you. I apologize.
no, I mean, go ahead. I'm just kind of gathering my thought a little bit.
Well, I mean, what's the atrial rate and what's the ventricular rate?
So the ventricular rate is quite slow. I'm seeing 1, 2, 3, 4, 5, 6 boxes, more than that. So less than 50 beats per minute for the ventricular rate. In terms of the
42 to be precise, yes.
in terms of the atrial rate, I'm not because I'm not seeing a regular rate between these P waves. It's almost there. It depends on whether I consider those deflections P waves that are coming after the QRS. I think that they are. I guess they are distinct enough, especially those ones on the far side of the strip. I suppose those could be blocked PACs because they're coming in earlier than the rate of the P waves that are coming before QRS.
Mm-hmm. Yep.
So I mean, I guess we can say that this is like there's sinus beats with blocked PACs. It's almost like atrial bigeminy.
Right. It is. For sure there's atrial bigeminy, right? Because this P wave, this P wave here is earlier than this, right? So seems to be what I guess we'd call a sinus beat with a ectopic atrial beat, sinus beat, ectopic atrial beat, sinus beat, ectopic atrial beat. Do you think though that these beats are, for example, normally let's say this is an 11-year-old, in an 11-year-old, should this P wave conduct?
Yeah, it looks like it should be able to conduct. An 11-year-old should be able to conduct an atrial rate at 100 beats per minute. So that should be
right. So what can we say about the conduction of this patient?
abnormal.
Definitely abnormal. Is this first-degree heart block?
No, because that would be a prolonged PR interval, so it's not first degree.
Okay. Is it third-degree heart block?
It's not third degree because there is some relationship between our QRS and our P waves. So I guess it'd be I mean, I thought I do see conduction at least in the first part of our strip, unless I'm mistaken.
The thing is, right? Remember that when someone is in complete heart block, the R to R interval typically does not vary almost at all.
Mm-hmm.
And as we're moving across this strip, we see some beats that appear to be conducting And then we start to see the rest of the QRSs are occurring at exactly the same rate as on the left-hand side of the screen. And yet these beats, this beat here is not physiologic, right? The PR in an 11-year-old is not going to be 70 milliseconds. This certainly, as you appropriately identified, is not going to conduct. And this also, unless somebody had WPW, should not conduct.
I see.
So this is basically, none of these beats can be definitively stated to be conducting. I agree that these look like they're conducting, but this to me looks to me like sometimes what we call isosynchronous beating, so that the atrium is going at its own rate and the ventricle at its own rate. And for a time, they seem to be in concert with one another, and then they don't, because they're actually not related to one another.
I see.
So I think that what this is atrial bigeminy with complete heart block. And the only way to know that for sure would be to see longer strips of this, and probably to do a Holter monitor on this patient, or maybe a Zio patch or something of that nature to follow the rhythm throughout a 24-hour period. This patient actually does have a history of complete heart block and has been followed for a long time. How would you determine, though, if this patient should get a pacemaker?
I suppose you can look at the function. You can look at how low their ventricular rate goes, whether they have pauses or not.
So the general approach, which we've reviewed in the past, is that there are actually official AHA, ACC, HRS recommendations for this. If you have heart block in a patient with a structurally normal heart, as this patient does. By the way, what would you expect you would see on the echo? Let's say the heart is structurally normal. What would you normally expect to see in a healthy person who is in complete heart block on their echo with a structurally normal heart?
I guess it depends on how long they were in it.
That's true. Let's say,
let's
say they've been in it chronically.
I think you would see the Canon A waves. I guess that wouldn't necessarily be on an echo, but I mean, you could see, I'm saying not specific to an echo, but you'll see that on an echo Doppler. I think you might have some would you have some LV dilation?
Yeah, because one of the compensatory mechanisms for slow heart rate is to try to increase stroke volume. And so, yes, each beat of the heart will have a larger stroke volume with to try and compensate. And so it's very typical that they'll have dilation of the LV in the setting of complete heart block. And this patient does have that, has LV dilation, which is a normal response to this. So the general approach is, first of all, if the patient is symptomatic, that is a 1B indication to put pacemaker in. But really what you want to look at is the average heart rate. Doesn't really matter so much the lowest heart rate, but the average. And the average, if the average heart rate is less than 50, that is considered an indication in a patient of this age. And although it's a soft indication, it's a 1B, I believe. Or 1A rather, sorry, 2A, not 1A, 2A indication, which means most people would do it, but it isn't absolutely definitively required. Also, if you see a pause of double the normal cycle length, and you have suddenly with wide QRS escape beats, that would also be an indication to potentially put a pacemaker in. So this patient has been sort of sitting around 50 on their resting on their Holters and Zios. And so we're thinking about putting a pacemaker in this patient. And what would be what kind of pacemaker would you put in? A single chamber or a dual chamber, Dave?
I mean, I'm trying to think about this. This is, how old is the patient?
11.
Would you put in a dual to get?
Well, you could. You could. I mean, generally speaking, the rule of thumb is we would put a single lead in a patient no smaller than 15 kilos because of concerns of vascular occlusion. And generally, we would think about putting in 2 leads at about 35 kilos. This patient is actually, I think, 55 kilos. But I was thinking about what I would do if I were to pace this patient. I actually was thinking I might just put in a V lead because this patient is not used to AV synchrony. And remember that the moment you put a lead in the vascular space, the clock begins to tick in regards to the possibility of vascular occlusions and difficulties in extraction and stuff like that. And almost every adult electrophysiologist will tell you that the cases that most frighten them are when they have patients with long leads that have been placed as children. The earlier you are that you have a transvenous lead, the more scarifying the lead generally is, more difficult it is to take out. So probably I would be very plain vanilla in this patient and put in a single lead on the theory that it would be nice to leave the vein as open as possible. A lot of people would not agree with that. A lot of people would put in a dual chamber pacemaker. It's certainly not wrong. I'm not sure what the right answer is, but that's one option. So, all right, good. All right, this is an 18-year-old who was referred for an irregular heartbeat. And this is the Zio patch that was obtained on this patient. And this patient, as you see, had an average heart rate of 85, a maximum of 222, which is what we're looking at on the left-hand panel, but had 45 PACs over 12 hours that they wore it, and otherwise no ventricular activity except for this one tracing. So Dr. Bonsall, what would you do if this was, what do you think about this Zio that the patient had? Actually, I'm sorry, it's 13 days and 4 hours, excuse me. So over a 13-day period, the patient had 45 PACs. First of all, what do you think about 45 PACs over 13 days? Worrisome, not worrisome?
Not worrisome actually, because it's like 45 events over 13 days. But I assume the Zio was
That's
done
correct.
for, sorry?
That's correct. That is a very low frequency of PACs. That would be well within the normal range for human beings. So yes, that is not particularly concerning.
But this short run of non-sustained VTAC that we see, it is present. I would like to do an echo, and then I would like to do a stress test to see if, I know it's over 13 days, the patient must have been active at some point during the time period, but yeah, stress test is something I would like to do to see if he or she is having it more frequently.
What would happen if you saw this type of rhythm in somebody during a stress test? What would you be concerned about?
CPVT.
Right, sure. This could be an example of CPVT. So I certainly agree with you. I would do an echo, make sure that there's not a cardiomyopathy. What cardiomyopathy would this be particularly concerning for? Or in, I should say. Well, the truth is any cardiomyopathy, right?
Yeah.
Any cardiomyopathy, this would be a worrisome finding. But if you had hypertrophic cardiomyopathy, right, this would be concern. This might be an indication in and of itself for an ICD, right? presence of non-sustained VT on a Holter monitor is actually a major risk factor for sudden cardiac death in the hypertrophic cardiomyopathy population, according to some data, certainly in the adult population. And by the way, this is an adult. So yeah, that's a possibility. So yeah, you would do an echocardiogram. What would you be looking for on the patient's resting electrocardiogram? Anything of concern?
Like related to cardiomyopathy or in general?
In general, if you see this.
I mean, if there are some PVCs, you could see them on a resting electrocardiogram.
Right. You also want to check the QT interval, right? Because
yes, to make sure.
Make sure this
There
isn't
is-
on QT, because truthfully, this is polymorphic ventricular tachycardia, which in the setting of a long QT interval would be also referred to as torsade. So this, you would not call this torsade formally if the QT is normal, which in this particular patient, it was normal. But if you didn't know that, you would do that. So it's interesting, so in the end, this patient had a stress test, which was negative, and had a normal echocardiogram. And so there isn't a right answer on how one would continue to follow such a patient. This is a patient that I saw with Dr. Obiaka, who was complaining of some palpitations, but in the end, this was an unusual, we both thought the patient just had anxiety, which I think we both still believe the patient had. But interestingly, had this very strange and kind of scary looking rhythm here. And so stress test will be done to show that there's hopefully nothing there. And then we're just going to observe this patient and maybe do another ZEO in the future, just to reconfirm that this was an aberration. But it's an interesting question, when you see something dangerous. This is not an indication for an EP study in a healthy person with a structurally normal, functionally normal heart. But you do sometimes observe things like this, and it demonstrates, I think, how who you are make changes the implications of finding something like this. If we saw this in a hypertroph, or somebody with very poor function with a dilated myopathy, or if we saw this in a patient with tetralogy of Fallot, we would be very worried, and we'd be managing this entirely differently. And we would, if it was tetralogy of Fallot, we'd probably do a VSTIM study, and we'd probably put an ICD in them. If we saw it in someone with hypertrophic cardiomyopathy, we would probably recommend putting an ICD in them. But in a otherwise healthy person who has a structurally normal heart, with normal function, with no congenital heart disease, we're almost willing to blow this off and not even do anything based on it. So it's very important to understand the history of your patient, and these types of arrhythmias can have different implications in different patient subsets.
How often was she complaining of palpitations?
Very rarely. No, I'm wrong. Very frequently, constantly. Tons and tons of palpitations. And you see here that these things that the ZEO calls a trigger anytime the patient presses the button, presumably because they feel something. And there were 8 such triggers over the 13 days, and they were all sinus rhythm between 87 and 124 beats per minute. So
would you consider propranolol for such a patient?
it's a good question. There are some doctors who would do that, but I guess I would ask the question, what are we treating? And how do we know that it is effective? You could put a person like, first of all, there's no evidence. If you're worried that this could cause sudden death, there's no evidence that propranolol is going to reduce your risk for sudden death from this. There is data that if you have like coronary artery disease and you have tachycardias and things, that beta blockers in general reduce all-cause mortality in that population of people with ischemic cardiomyopathy or ischemia. But there's really no evidence that it's of any benefit in somebody like this with a structurally normal heart. Now, you could put them on a beta blocker if you were worried that this was exertional. You call the patient up, you find out that this occurred while they were playing basketball. If you were nervous, you could put the patient on a beta blocker until such time as you're able to do a stress test. If on stress you start to see a lot of polymorphic VT, then you could go down the genetics route and such, and keep the patient on a beta blocker until you have a diagnosis. But if you do not know that this was associated with exertion, and if everything else was normal, I'm not really sure what we would be treating by starting a beta blocker. I think we would probably be treating ourselves, not necessarily this patient. So I just thought this was an interesting tracing because sometimes you do these monitors and you identify things that you don't actually even know what to do with. This was quite a surprising finding. I think Uzo and I both felt that this patient, by the history, by the physical exam, which was completely normal by all measures, there was no evidence for any kind of, or certainly no concern on our part that this patient was going to have anything. And in fact, went 13 days, didn't have even one isolated single PVC except for this. So it's kind of interesting.
That is actually very unusual. Like you would normally see some PVCs if you see some runs of non-sustained.
That's exactly right. You would normally see lots and lots of PVCs and then see a couple of runs here and there for different types of conditions associated with ventricular arrhythmia. So this was a very odd thing. And because the patient only had one episode over the entire 2-week period, I feel more confident than most in sort of, I'm going to follow this patient. I'm going to do a stress test. I'm going to tell the patient that if there's anything beyond a palpitation, I want to know about it. I might do more monitoring, but I'm not going to do anything more than that unless I can show that this is something that's happening with some relative frequency. So it's an interesting finding on a tracing in someone who we thought was completely fine, and probably is completely fine, by the way. All right, I'm sorry to cut it short a little bit this morning, but I have 1 or 2 things I have to do before our first case of the day. Thank you very much for joining. I hope everybody has a really great day, and I'll see you guys in the cath lab in a little while. Bye.
Thank you.
Thank you.
Bye-bye, guys.